Any questions? Well, people are looking into questions. The next portion of our program is the panel. So Eli, don't go that far away. Yeah. So I would like to ask Dr. Paul Hendrie from the United States to join us on stage. Also, Eli from the United States will be joining us, followed by Dr. Matthew Collins from the United Kingdom, Julien Haroche from France, our host, Xavier Solanich, and Augusto Vaglio from Italy. Please join us on stage. This was going to be a 1-hour panel with questions with the experts. So if anyone had a question for Dr. Diamond, we can start with that question. You can sit. Yes, they'll bring them. Yeah, moderate. Yeah, so Dr. Paul Hendrie will be moderating. So it's right here. What do you need? Microphone? I think someone should bring one.
Hello. Is everyone still awake after lunch? Or? So I'll just, I'll let these experts get seated here, and then if you have a question, just raise your hand and I'll come by, and if you need help getting it through or translating, maybe Juvie can help there too. But just if you can just raise your hand if you have a question, and we'll get started.
Afternoon. I know Prof. Collin knows me quite well. So my question is, right, I've recently become confirmed BRAF positive. So quick chat with both Matt and Eli. Are the advantages of MEK inhibitors of being BRAF positive? Because at the moment I had MEK treatment funded, but we didn't start it because I became known as BRAF positive. Is there any advantage of having a combined treatment, even though it's BRAF positive and not MEK positive?
Simple answer is yes, it is advantageous to have two treatments. So I'll just take this off. I'm getting my voice twice in my ear. Eli will probably have something to add, but the efficacy is higher and the side effects, curiously, can be less with two drugs than with one drug, particularly if you have dabrafenib alone, you can have fevers, and that can be attenuated by dabrafenib and trametinib. And also I find each drug has its own side effects. They tend to be unpredictable. So if you start with two, you can usually adjust the doses of the one that's, say, more problematic than the other.
Yeah, I agree with what Matt said, and I would just add that I don't think people often reach for the MEK inhibitors for BRAF mutant disease, but they can be an acceptable treatment alone. I can't say there's a vast experience, of the 26 patients in the Kobe trial that led to that approval, 6 were BRAF mutant only. So I think that it's fair, and then I think it depends on what types of side effects you're dealing with from the BRAF inhibitor. Some changing the BRAF inhibitor may work, some adding a MEK inhibitor may work, and sometimes just changing to the MEK inhibitor may be a good solution.
Is there any different approach in Europe then?
Different approach to
Europe.
Yeah.
With the between the Europe and the States as far as using two drugs versus one drug, or is it harder to get two drugs?
You mean combined treatment? Well, we have a limited experience in Italy with MEK inhibitors in Florence. We only have a few patients, and none of them is in combined. I think it's a little bit more used in the center in Milan. But we had recently a couple of refractory cases, so we had to change MEC and so on. But it's always off-label use, but it's possible. I mean, it's not difficult to get. I mean, it's a long process, long application, but it's okay.
Yeah, I think that there is like dual therapy. It's really important when you have a RAS mutant and maybe also TP53 or a problem of non-control evolutive CMML or other myeloproliferative neoplasms. But for the two last, there is not really any proof of that. If you have many mutation on the clonal hematopoiesis, then you can discuss. And one of the problem of dual therapy, in our experience, among maybe 25, 30 patients, probably more right now, is that it's in the contrary to metastatic melanoma, when you combine both, you have additional toxicity, whereas in the trials that was in metastatic melanoma back 15 years ago, you had more efficacy and less toxicity. I don't know why in the field of histiocytic neoplasm, it's not the same. And we use it sometimes, we use it like frontline, not giving just a BRAF inhibitor or a MEK inhibitor when you have severe CNS lesions. I don't know if we're right, and also recent onset of neurodegenerative disease, or if you have tamponade or pre-tamponade as well. But we don't know if we're right to do that.
Great. I think we have another question here.
I'm asking this question for Edith. Edith leads the Canadian chats with other Canadians, and they talk a lot about Mekinist and Tafinlar. And the general consensus there is Mekinist seems to be a pretty strong drug. And there are a few Canadian patients that she's talked to that seem to have difficulty with it. One is allergic, one has immune issues, and in Edith's case, it was reduced because of lymphedema. Is it possible to take Tafinlar on its own, or is that not a treatment plan?
The question was for you.
Okay. So the Mekinist, just for everyone, Mekinist is trametinib, which is a MEK inhibitor, and Tafinlar is dabrafenib. There's some people have a very rough time with trametinib, and other people don't. And I think these things they're highly variable. I have patients who they do fine with Mekinist trametinib, and some people have a horrible time, and then you change it to cobimetinib, and things are so much better, and vice versa. So I don't think there's one overarching statement about them, except that some may maybe more likely to cause liver and kidney versus the other. But in terms of like overall tolerance, I think that it's kind of case by case. And then if your question was for BRAF mutant, then the Tafinlar dabrafenib alone can be sufficient, but there are sometimes these other instances, neurologic disease or other mutations present, where you'd want to add the trametinib for a variety of reasons.
I would just agree that dabrafenib monotherapy can be fine for some people.
So if ECD can be causing neurological issues, even if you have a clean scan, and some of the neurological issues are things that could also be caused by other conditions or other meds you're taking, or the med you're taking for ECD, how do you parse that? Is there any kind of protocol for trying to figure out what the cause of, let's say, brain fog, or the cause of balance issues, or et cetera? How do you how do you sort through that, or how do you recommend sorting through that?
It's definitely a question for Eli.
I'm often unable to answer it. I would say that if there are issues with speech and balance or eye movements, that puts you in that's a direct ECD manifestation. And then the other stuff is murky, is it from inflammation in the body and those inflammatory chemicals sort of turning the brain down? Or is it, there's some evidence now that perhaps there's actually microscopic ECD in the brain that we're just not seeing on scan. So I think you have to just, sometimes I try to increase the ECD treatment temporarily to see if it helps, and if it doesn't, then we sort of try to think about other things, but it's a challenge for sure. I don't know if anyone has any other.
I mean, concerning drug versus ECD, if you have post therapy with 1 week on, 1 week off, that can sometimes help. I've asked people which is the good week, when you're on the drug or when you're off the drug, and it's a crude tool though, so it can be tricky.
Can I add something? Although I'm a nephrologist, not a neurologist, but I think that even if you don't have MRI detectable or CT detectable brain disease, you might have some mood disorders, and depression is a cause of brain fog sometimes. It's not frequently, of course, a cause of ataxia or gait disturbances, but from a cognitive point of view, I think considering mood disorders as a potential cause is important, especially in patients with a chronic disease.
Is there a class of drugs that is better used for mood disorders in ECD?
You mean a class of antidepressants? We normally use different types. I mean, it's generally, I would give it to you. It's generally on the basis of like a psychiatrist's advice, but we don't have a preferred class of drugs. At least in Italy. Let's see in France.
What am I going to say? No, it's the same. I agree with him. The only you should be cautious for picking up drugs. We do not give QT prolongations if you have a BRAF inhibitor. That's my only. So I think, for instance, Seroplex, I think is not very good, or you have to check that more regularly. And there is many drugs that interfere, and some who do not.
Thank you. Bear with me, there's a question in here somewhere. I'm interested in the situation where you're on treatment and it's all working well, and by virtue of the treatment, the mutation has been switched off. You're no longer getting that proliferation of bad cells, but nonetheless, before the treatment became effective, you had a buildup of bad cell sclerosis and so on in and around the body. Do those bad cells simply get dispelled through the normal order of things in the body, or are there some sort of long-term issues that the body will still have because for example, your leg bones are slightly damaged or your retroperitoneum is slightly damaged? I mean, clearly, when you see the scans, it goes from, you can see the ECD and then it's largely gone. But how much gone, I suppose, is my question. And is there anything that as patients we should be thinking about or concerned about in terms of residual effects, even though the treatment's going well?
I go ahead. I think that I mean, if I got the question correctly, if these cells are they disappear or they remain quiescent, or where are they? I think they are. If you look at the lesions with MRI or CT scans, and you can see that there is a regression in most cases. So this means that some cells are killed. But the problem is that, as Julien demonstrated in the LOVE study, for instance, if you stop the treatment, you have a very high rate of relapses, which is quite fast, because the median time was about 6 months. So this means that we probably leave the time to the few remaining cells, or to the remaining cells, to react, to become active again and to restart proliferating. So I guess you don't get rid of the disease. Even if you switch off the lesions from a metabolic point of view, from what you can see on PET scans, there are cells, maybe in the bone marrow, maybe in the residual lesion, but anyway, there are cells that can come up again.
Yeah, and so, some of for instance, there are some patients with absolutely massive perirenal infiltration with normal kidney function, no high blood pressure. It's just like a iconic pattern of the disease. And sometimes with the treatment, for instance, with a BRAF inhibitor in the case I'm thinking about, there was a slight regression of the perirenal, which went from 3 centimeters to 2, I think. And it was an avid lesion. Then it became like the SUV was normal. The patient had no sign, and over time it stayed like that. So there is this scar of the disease. In this example, it was around the kidney, and so maybe in this type of situation, you can maybe taper a little bit BRAF inhibitor, and nothing will happen. I don't know if this addresses your question. Sometimes you will normalize certain aspect of the disease to one point, and then you keep on with the sequelae or the like a radiologic scar, and with no or very little clinical implications.
I think your question was, should you be worried that there is something under the surface? So to answer that, I think if you're feeling well and your scan is responding and your side effects are not a problem, then you should not be worried. So it's very important to find out how the patient is feeling. There's no point to take a high dose of drug just to make the scan perfect if it gives you side effects, for example. And it is possible still that we haven't used these drugs long enough to know how good they will be in 10 years, 15 years, as in they could go on working and suppressing the disease, because there are some other blood cancers where people can eventually come off the treatment if they have a super good response. So I'm thinking of myelofibrosis and chronic myeloid leukemia. So the field is too young to see if that's possible in ECD, but it remains possible that you could maybe one day stop treatment. We just don't know.
Another question from me around maybe eye involvement. So either disease or drug involvement of the eyes. Should you, via optician, or go straight to an ophthalmologist, get referred to ophthalmologist for eye conditions if you think you're having them?
I mean, probably ophthalmology.
I mean, I think there's probably a variability in the availability of eye specialists in certain contexts. I'm very fortunate in that my eye buddy is like one floor down. And perhaps if I didn't have that eye clock, I would have a little more skill myself, because sometimes I push the emergency button and someone has dry eyes, and I've created a big production out of something that was not all that big a deal. But for people on, I would say on MEK inhibitors, some sort of screening of the retina, I think is probably pretty fundamental. On BRAF inhibitors, I think it can probably be more based on symptoms. I don't know if others agree or disagree.
Yeah, I agree. I think for the screening of someone who's on the MEK inhibitor, it's very simple. It's called fundus opticus. I mean, like every basic, actually, it's something like for the medical examination to become a resident in France. It's a part of the clinical examination, and you can be tested. I could be tested with like looking. So it's supposedly easy to see if you have, if your retina is okay or not okay. And so it's a basic stuff to do for at least an ophthalmologist, just for that. Yeah.
First of all, thanks to the panel for bringing the combination expertise and expertise. This is not just a job for you guys. This is a cause, and so we really appreciate it. My first question is probably directed to Dr. Vaglio. I belong to the subclass of patients who have refusal complaint. I think it's renal involvement. In the first diagnosis, I underwent a nephrostomy where they drained my kidneys, and then there was a question of what to do after that. So the first thing they did was they intubated me from the back, and that, of course, wasn't a very good solution. The next thing was I was in stented, and I've been stented since 2002. And so when you mentioned that it's a temporary solution, after 51 procedures, it doesn't seem very temporary. So I think I've tolerated these procedures fairly well. I apparently tolerate anesthesia, but is there anything else in my future that you can think of?
Yeah, thank you for the question. And I think that in theory it should be a temporary solution. Actually, the fact is, I mean, in reality, what we see is that this is usually a chronic stenting, and you have to undergo stent replacement from time to time, from every 6 to 12 months. But I have something to say, which is a little bit probably provocative or against the common practice. I think that for this disease, we use stents more than we should. Because I think we put this in the renal paper as well, that when we compared in the few patients that we had with available data, before and after stenting, the function of the kidney did not improve that much. So the problem is that you put the stent every time you have a well-definite obstacle, like a stone, like a small tumor, or you know, whatever stricture you have. But the problem is, this is my personal opinion, but I think the problem is that the infiltration is not only of the ureter, but it's also of the upper part of the urinary tract. So what we call the calyxes. So between the kidney and the ureter. Therefore, it's not like bypassing a stone. It's not like overcoming a stricture. In that case, you have a diffuse obstruction of the urinary flow. And this is why I think that sometimes, I'm not saying all of the times, but sometimes this is overused. Last chance, or at least you can have nephrostomy, but that has to be temporary because it's too bad for the quality of life. So you have to turn into stents first. In patients who are refractory to stents, they tolerate bad, they have infections, bleeding, and so on. There is also the option of the surgical ureterolysis, which is the type of surgery that relieves the obstruction in a more or less permanent way. We had in our cohort, I remember just one case who did so, and so that we cannot conclude anything. But we had also patient with the Rosai-Hoffmann disease with a huge perirenal involvement who underwent surgery for this kind of surgery, which is called ureterolysis, and it worked. So I think that good surgeons can do that.
I wanted to add something, like sometimes in medicine, medical condition, like for instance, if you treat myositis and sometimes you give IGIV for several months, years, and sometimes you never figure out, you keep on with, that's an example I give with this regimen, and you never stop. And I guess I have a few, I'm not speaking about you, but I have one or two examples in mind. For instance, a patient who had some GG stents change every 6 to 9 months. And after a couple of years of BRAF inhibitor or MEK inhibitor, I don't remember, the disease seemed to be controlled with a negative PET scan, etc. And so the patient was always asking, do I still need to have the stents? And so then you have to discuss with the urologist, and because they sort of mechanically change every 6 to 9 months. And the possibility is if there is no dilation of the pielocalicial cavity, if you have no hydronephrosis, you can try to arrange with him, but that's a problem for the patient, is to take off the stent at one point, and then to check with renal ultrasound that after 2 weeks, maybe 1 month and 3 months, that it does not re-dilate. And in this case, you would have to have 2 surgery and to have general anesthesia and to put back stents. But that's a possibility in certain cases, and so maybe it's important not to change like for lifetime in certain cases.
Je voulais vous demander une question. Est-ce que les douleurs osseuses peuvent être migratoires? Est-ce que se manifestent à différents endroits?
Vous voulez dire, est-ce que c'est...
Des
So,
douleurs.
should I
On
speak in English
n'arrive
or in
pas à
French?
trouver l'origine des inflammations. Donc, j'avais des douleurs au niveau de la poitrine. Et d'un coup, quand ils ont fait des radios, ils ont demandé si j'avais des fractures.
Des fractures sur les os longs, ou c'était des fractures ici?
Ici.
D'accord.
Au niveau de la poitrine, les os longs, de toute façon, j'ai toujours des douleurs dans les os longs. Et d'un coup, au niveau de la poitrine, il s'est avéré que il se demandait si j'avais pas des douleurs, des fractures.
So, am I supposed to answer in English or in French? English, okay. So I think there is no parallelism between the long bone uptake and bone CT scan or PET scan, which is present in most of patients with Erdheim-Chester disease, maybe 90% or a bit less, and the patients and the bone pain of the patients who are a bit less than 50%, and sometimes it's really mild bone pain. So, and I imagine you can have pain in various locations, and it's not just the lower limbs, unless, despite the fact that it's the most, it seems to be the most affected involvement for pain. It's usually lower limb, but it's not systematic.
Sometimes we don't see inflammation in the bones, or but the pain persists, and we say how it's possible. But it's very common that the pain and the fatigue persist even when the disease is in our point of view controlled.
So, Eli, not to put you on the spot a little bit, but I know you study health-related quality of life, which is an important aspect of feeling better. And we heard a talk last week from an endocrinologist who was speaking a bit about endocrine issues and histiocytosis, and the role of oxytocin, and with that potentially being low when a patient has, ABPD or pituitary or endocrine issues. Can you just comment a little bit on what you remember from that for the families here to potentially speak a little bit to their doctors about that? Just can create, I guess it's sort of involving the mood disorders and things like that.
Yeah,
Thank you.
Deanna is referring to a really very fascinating talk that we heard a few days ago from an endocrinologist in Basel, who has pretty much made the observation that many individuals who have that hormone deficiency of diabetes insipidus also have a lowering of this hormone called oxytocin, which is associated with a feeling of well-being, kinship, happiness, satisfaction. And then this endocrinologist has done a lot of very interesting experiments demonstrating that individuals with DI do not respond to normal stimuli that generally raise the oxytocin. So it was very thought-provoking in terms of one aspect of mood and well-being that could be in a blind spot to us up until now. So we'll be looking forward to what he actually sort of puts out in the literature on the matter, but it was very interesting.
So it was diabetes insipidus of any origin, or it was just diabetes insipidus in the setting of histiocytic?
It was any. The thought was triggered by someone with LCH who got him thinking about it for a variety of reasons. But then he studies people with DI for many reasons. Yeah.
I have a question about potential future treatments, because I know recently, hi, back over here. Recently in the US, there was a somewhat successful gene therapy experiment done on a relatively rare other disease. Is there potential far future research that would also be helped by for ECD?
Gene therapy specifically?
Yeah, gene therapy or other, because like right now, kind of BRAF and MEK inhibitors are kind of the state of the art. Are there other promising fields? Gene therapy is just one I know of. I don't know if there's anything else that isn't being looked into right now, but has some promising future for ECD.
Yeah, I think it's possible that there are other drug targets that could be exploited. Do you want to comment on BCL2?
I know that some people want to try, but I'm not sure if it's going to happen, but it could be CAR T cells, but I'm not sure it's going to happen. But apart from that, I don't have any other ideas of gene therapy.
There are some treatments for some clonal genes that are associated with Erdheim-Chester, like a recent study shows DNMT3A, which can be a background mutation. If you are taking the diabetic drug metformin, you have a lower expression of DNMT3A. And there's also TET2. There are some treatments in oncology that can suppress the function of TET2. So I think it's possible we might see some other drugs coming in from other blood cancers to help. I guess at the moment the inhibitors are very good, but it may be that an early stage where there's a small amount of disease, you might want to add some modifying drugs. I don't know.
I don't think this is along the lines of gene therapy that you mentioned, but this monocyte, sort of the part of the family tree that ECD and the other histiocytoses live in, they're maintained by this other signaling pathway called CSF1R, and there are blockers of CSF1R that are used for an entirely different disease, and there have been some instances of ECD patients treated with these CSF1R inhibitors. I think it's fair to say that if we could all snap our fingers and figure out what happens to 50 ECD patients who received a CSF1R inhibitor, we'd be very, very curious. It's hard because there's the competing factor of the BRAF and MEK inhibitors working well, and how are you going to get and do that? But I think that it's fair to say that that's a treatment that we'd all be very curious to find out what happened and who it works for and who it doesn't.
Yeah, again, with respect to CAR T cells, because we just had a lecture on CAR T cells in another systemic disease, which is lupus, and they apparently work. So these therapies were born in the hematological field and they were translated in other fields. So they were born for lymphomas, for hematologic malignancies, but they're now used or applied at least in many different diseases. And apparently, if you have the right target, like I don't know, a CD68 from one site, or you have a specific target for these cells apparently kill very efficiently the tumor cells or the pathological cells. And I believe that this will be attempted in the near future, because there are many centers using this procedure for let's say, lymphomatous diseases or diseases of many different origins, including inflammatory diseases. So I think that even for the widespread, the more and more widespread use of this technique, there might be some application in ECD as well, and apparently it's working well in many fields.
I'm glad I'm not paying for the questions because I'd be skint. So question about the urethrolysis, because they've tried that on me. So my little
the surgical one?
Yes, yeah. So I had keyhole surgery. My little corner of the UK down in the southwest. A guy called Mr. Bush, who's apparently one of the best urologists around. Apparently the fibrosis was not normal fibrosis. I know I've had a discussion with Matt around this a couple of years back, where he literally just couldn't see anything and the surgery failed. Are there other advancements in how to be successful on that? Because like Joe, although not as many as Joe, I'm up for my 10th stent change next month. And the lifelong thought of at 45 and now 51 of 10, at 65, 70, 85 still having stent changes is not high on my Christmas card list, shall we say,
I totally understand. What I can tell you is that I have seen people doing urethrolysis in a different disease, which I'm quite familiar with, which is idiopathic retroperitoneal fibrosis. So it's still an infiltration of the retroperitoneum, but it's not due to ECD. And this type of surgery is quite feasible and doable, and it works well in these patients long term. So this is encouraging in a way. I think this has not been tried enough in ECD. The disadvantage of ECD is that most of the times this infiltration is quite large and diffuse, so it might be difficult to find the ureter and extract it from the retroperitoneal space. But we treat in Florence, we treated two or three cases in general with robotic ureterolysis, which allows a much more precise visualization of the organs, and it's less invasive. It's not an open laparotomic surgery, so you don't have a scar. There are many advantages, and I think that robotic urology is really coming of age. And in my opinion, this is really something to think about. And we did it in a patient with a massive Rosai-Dorfman disease, which involved the kidney and the ureter. And this patient, at least on one side now, has been treated and is okay.
Thank you to my fellow patient for asking the question following up on ureteral urolysis. I recall that I asked about my doctor at that time about the procedure because there was a 2005 article in which a patient underwent the treatment and unfortunately subsequently had to go into hospice care. So thank you for that. My new question is probably most directed to Dr. Diamond. And as far as cognitive changes, I was wondering, is my age something to do with it? Because I'm 71. And so that's question number one. Question number two, directed to the panel, is stem cell treatment basically replacing somebody's immune system with new immune cells still a possibility? Thank you.
Yeah, I'd say to answer your question more generally, there could always be other causes of issues with thinking and memory, age-related, things like blood vessel, I'm not saying you have high blood pressure, but things like what we call vascular risks. And so those are absolutely considerations. And then certainly with age, those become competing considerations. I'm not saying that this will necessarily serve you, but sometimes detailed testing, if those are bothersome, can tease out because there are more typical patterns of age-related type, word finding difficulty, things like that. But the answer is yes, for sure.
I'm a transplant doctor as well. I'll try and answer your transplant question. I think there are two potential reasons that it doesn't look like an attractive therapy. The first is, and I'm talking about the kind of transplant where you maybe put well, it doesn't matter actually, true for both types of transplant. You need to have a treatment just before the transplant that's very effective in removing all traces of the disease. And second, you need to, I've forgotten the second thing I was going to say. So let me stick on that one. The drugs we have are long-term drugs, so we don't have a high-dose chemo, for example, that will work. I know the second thing I was going to say. The nature of the disease is puzzling because if you were to do it for something like myeloma, say, which is a common thing, you can see plenty of the disease in the body when it's active. In Erdheim-Chester, the bone marrow that you're replacing, sometimes it's very hard to find the kind of root of that disease. So a very low level of disease could persist after the treatment and still maybe the disease would come back. So I think those are the two sort of theoretical reasons that people haven't gone there. Then there are other problems with if you have organ impairment, say respiratory or cardiac, renal, that can make the whole process more challenging as well. So we would probably prefer to stick to slower treatments that are more gentle. That would be my view.
Yeah, I think my former boss published a paper in 2001 with a major exophthalmos, like absolutely massive one, and he was refractory to, I think, 2-CDA, high-dose interferon, and then he had an autologous transplant, and it was a success. At least for, I don't know, 7-8 years, he was in remission. And then we published, I think, 6 patients who had autologous transplant. And I think there was 1 death and 5, I think it was considered as not really successful. And I think the massive chemo that was done before was partly responsible for the efficacy. And then I'm not sure that because you have 2 parts in a transplant, you have the chemo before and then the transplant in itself. But it was like non-conclusive as a success overall.
Do we have another question out there?
Quick question. Once the disease is stable, is it necessary or how often to take a PET scan after?
Well, I can start. If normally we do a PET scan at the time of diagnosis, then when we start treatment, we repeat it at 6 months and then maybe at 12 months. And then the frequency, if the patient is stable, usually declines. So we do it sometimes every 2 years. But you might also follow the patient up without PET scan if there is no clear sign. I mean, in some cases, if the PET is negative, is repeatedly negative, and you only have, for instance, neurological sequelae, neurological symptoms, chronic symptoms, we usually image the patient with a brain MRI, and that is it. And for the rest of the body, we do very cheap and non-invasive and non-radiating techniques like echocardiography or abdominal ultrasound.
I use too much PET scan actually, and I especially in the beginning of the era of targeted therapy, just to make sure to assess the efficacy of the treatment, and then I use it. Then I use longer intervals, but I sort of even when you reach a plateau, I still do it once a year, unless it's completely negative or you just have a residual uptake of the long bone and no clinical signs, then I stop. But as soon as you have some little involvement, I keep on with once a year, and it's probably a little bit too much, but I should probably get larger intervals, I guess, especially for the nuclear risk of my hospital.
It's worth remembering that the CT part of the PET CT is not as detailed as a normal CT, which is a cheaper, sometimes better test. So once you know where the map is, you can sometimes follow with a plain CT just as good.
Yeah, I would agree with Julien. I think we're all backing off from frequent PET CTs because I think that when the targeted therapies were first used, it was so dynamic, and so we would see the disease would turn on, it would turn off, and we did them more frequently. And now I think when someone is landed on a treatment that is working, it doesn't feel like we learn very much from doing them frequently. So I think there's two issues. One is, are you learning something from the PET? And then is there a downside to it on its own terms? And so I think probably tons of PET CTs in very young people may have a cumulative risk over life. I don't think, a moderate number of PET CTs in people who are aging, I don't think carries the same risk. So I think that's one question in terms of the age and how many PET CTs over life. But then I think we're realizing for people who are doing well and who aren't changing their treatment, we're not learning as much from it doing it as frequently. And maybe you can pick their most affected organ and just do an ultrasound or an MRI of that.
I just want to remind anyway that PET-CT has an important advantage, and this is a screening for cancer. So no one really does a PET-CT for screening cancer, but when you do it for other reasons like ECD or other diseases, you can screen other cancers as well. And we saw from Francesco's presentation this morning that there is an increased frequency of cancer in patients with ECD. So it isn't, with this, I don't mean that we are going to do PET-CT routinely for cancer screening, but actually I mean that we have to be always surveillant on screening cancer. And most of the cancers, of the solid cancers that we detected in our population, which was, I think it was mainly Italy and France, were also common types of cancer. So it's like prostate or breast or lung. So it is very important not to forget that such patients are at risk and that we have to screen with the appropriate methods.
And nowadays we use the PET scan because it's available at the most of the centers. But now in this hospital we have the PET IRM, the PET resonance. That I think it's very useful for this disease because it's better to see the soft tissues like the kidney and also the brain. And sometimes you are not able to see well the structures and well which part of the brain is affected using a PET scan. And with the PET resonance, you can see the progression and exactly which is the tissue, the part affected. So nowadays the gold standard is the PET scan, but I think in the future we will have new techniques to detect the disease.
At the moment, there are two molecules that are in the US market. Do you know if there is any plan to license those molecules in Europe too, or if there are new molecular in research that for future would be licensed? Thank you.
So mainly BRAF and MEK inhibitor, I imagine. I think most of European countries can have access to the drug with more or less complicated process to get from a country to another BRAF and MEK inhibitors. Sometimes it's more complicated to get MEK inhibitors, and it's overall reimbursed in, I think, in all of Europe by Social Security. The only problem is we don't have a formal approval of the drug. There is no EMA approval. There is, at least for BRAF inhibitor, but I think for MEK2 and in some European countries, you have what you call orphan drug designation, which covers, which allows you to give in a practical way to patients these drugs. As for the CSF1R inhibitor that Eli was talking about, it's pretty strange because there is an FDA approval in the US. And in Europe, it's absolutely no way to get it, even like trying to convince the two the two companies that make this drug. And they say that there is no EMA approval for liver toxicity, which seems to be acceptable in the US and not in France and Europe. So I don't understand why. And we're every other month trying to get access to these drugs. And basically we have access to the 3 BRAF inhibitor and the 3 MEK inhibitors in Europe. The only thing is that some of the drugs are less accessible from a country to another, I guess.
Well, in Italy, you know, we use it because this is classified under the rare diseases group, and then patients with rare diseases may have access to different drugs. But yeah, this is a good aspect of our Italian system. It's that provides some support to patients with rare diseases, and I think this is very important.
D'abord, je vous remercie pour toutes les recherches médicamenteuses que vous faites, mais est-ce qu'il n'y a pas un autre moyen pour nous en fait de vous aider au niveau, par exemple, de ce qu'on mange ou d'une activité sportive, mais qui peut correspondre à notre état de santé? Merci.
You don't speak French, and I don't speak French.
Could you translate the question? Or?
Yeah. So the question is there anything that the patients can eat or do as physical activity, or I imagine to limit the burden of the disease or to improve? Maybe you have some insights about that.
I wish I had something more ECD specific or exciting to say, but general suggestions are to look at nutrition in terms of some possible vitamin deficiencies, which can be common in ECD patients, and then addressing sleep, because sleep can be, I think sleep disturbance is underestimated, I think especially for ECD patients who may have had a course of steroids in the past or who have any neurologic involvement. They may have sleep disturbance, which causes quite a bit of brain fog. And so it's trying to come at all the different medical aspects that you can. And then, although this is not easy, I think that people who are able to do regular exercise, I think, across cancers is helpful for energy and thinking and memory.
I think the next 2 or 3 talks are about these aspects of the disease.
With regard to the kidney, if the kidney is constrained by the fibrosis, can you just remove that kidney into the lower part of the body, out of the ECD area?
This kind of approach, which is called nephrectomy, so removing the kidney, is performed only in patients that have usually other types of complications. First of all, infections. If you have infection of the kidney, and this is not treatable using antibiotics because it is resistant, because you have stagnation of urine in the kidney, that is in some cases, especially when the kidney is small and probably non-functional, that's an indication for the kidney removal for the nephrectomy. But in other cases, usually not. It is difficult to debulk the tissue, so to remove the tissue only. If this was part of your question, I don't know, but anyway, the debulking is quite difficult because it's highly fibrotic, so it's like a scar, so it's hard to remove, and it's quite tightly attached to the organs or to the retroperitoneum, for instance. So this is a difficult type of surgery, and it's never performed just with the, or at least not in the retroperitoneum. It's performed with the purpose of debulking. Debulking is used sometimes when you have eye involvement, because you might have compression of the nerves or the eye itself. And so debulking is used sometimes, but it can be used anywhere in the body, but it's usually difficult to remove the whole lesion. That's the point. And if you remove one kidney that has perikidney involvement, it doesn't really affect ECD in the rest of the body. So there's no influence from the removal of a part of the tumor.
So I think that's our hour. Excellent job on the questions. Thank you, everybody. And panelists, excellent job up there.